Well, we've heard a lot of good evidence looking at the vertebral augmentations. This is a little switch. This is some work that I've been doing over the last number of years on robotic-assisted spine surgery. And we really just want to try to introduce this concept. Again, in the spirit of disclosures, I do have a relationship with each one of these entities, one of which is the company that actually manufactures the robot that I've been using, that I've been involved with the design and development. As surgeons, we always want to be in control. This is what it's about. We don't want to have this sensation of impending doom. We're in the middle of an operation and all of a sudden we don't know where we are, what's going to happen. The wheels have completely fallen off. Robots are here to stay. It's part of life today. The cell phones that we use are made by robots. Our luggage is sorted at the airports by robots. So this is something that's here. And in the medical side of it, it really hasn't integrated yet into what we're doing. But now there are robots that can do rounds for us in hospitals. There are robots that can go into a hospital room and sterilize the room for us. And we're now just getting these robots into the operating room to assist us as surgeons. There's different types of robots. Robotics is an umbrella term, but you've got passive robots, semi-active robots, or active robots. Passive robots are robots that just sort of move in space and position you. Semi-active robots can actually do something for you, can drill a hole partially. An active robot can essentially do the whole operation. And these are the things that are coming right now. Right now, we're able to perform some surgical procedures. Some may be familiar with this type of robotic apparatus. This is the Da Vinci type of robot that the surgeon sits remote and does the operation, and the robot at the bedside mimics what the surgeon's doing at a remote station. What I'm going to be presenting is the work that we've been doing with essentially a passive robot. This is a positioning tool in three-dimensional space. And really, it's not that exciting a thing. It's about the size of a can of soda. It's got these 6 turnbuckles or pistons in it that move, these 2 plates top and bottom, and then a sidearm. So it just twists in 6 degrees of freedom to position you in space. The system supports open and percutaneous type procedures. So you can do anything from major scoli reconstructions to percutaneous pedicle screws to percutaneous vertebral augmentations with this type of technology. It provides for positioning for accurate and precise placement, but the key here is preoperative planning. And I'm going to say this a couple times because in my experience with this and working on this project for a number of years now, the one lesson that I have learned is how important preoperative planning is to us. And it does provide that operative control. There are different systems out there, but the system that I use has 4 components to it. You've got your preoperative planning software, you've got your C-arm image adapter, and this is what helps do the registration. You've got your workstation where we do the planning and it integrates, and then you've got your surgical accessories. And again, here's just the device, and looking at the inside of it again, you can see the size relationship to it. We mount the device onto a fixed bony prominence, and we have 3 different types of ways to mount it with a spinous process clamp, a bed mount frame, or what we call the hover T-frame, and the robot essentially just translates up and down, side to side on those frames. Now, how many here, if you heard that you were going to go on an airplane and you heard that the pilot didn't do his pre-flight plan, didn't check how much fuel he has on board, didn't look at the weather up ahead, didn't take into account the geography, how many would go on the airplane with that pilot? Nobody. Likewise, if you had a contractor come into your house and he was going to remodel your kitchen and he didn't show you a blueprint, he didn't show you what he's going to do and a budget, would you hire that individual? No one would. But for years as surgeons, we've had our patients, we look at an x-ray and we say, yeah, we'll cut here, we'll move this, we'll do this, do that. We have the plan in our head, and then when we get to the operating room, something completely different happens. It's never exactly what we planned out. Now we've got the tools, and we're in a privileged position now that we can pre-plan. And I'll show you evidence that really reveals that the pre-planning helps with the efficiency, helps with the accuracy of this. And it's something that we've just taken for granted, but it's really, really important. So this is the procedure flow and the preoperative planning, and this is critical. And this is the software that we use, and I can take the screws and move them in three-dimensional space, position them exactly where I want in the vertebral bodies. If we're doing a vertebral augmentation, we're positioning the trajectory of the needle or the position of the balloon, where we want that balloon to be. I can change the size of the screws. I can change the diameter of the screws. We've got all sorts of different variables that we can play into it. And then we can check the position of the screws in the sagittal, coronal, and axial plane, essentially slice by slice, looking exactly where it is. When we're dealing with pedicle screws, one of the things that we really want to ensure is that we are not violating that proximal facet joint. We're maintaining the integrity of that facet joint. So here you can see we're coming down through, and we've got the screw in the position that we want. It's a little bit too close to the spinal canal there on that left-hand sided screw, this one right over here. So we just move the screw over a bit and continue on and check its position in all the different planes. Repeat the check in the sagittal plane, going right down. You can see the screw, we know where it's going to end up, and you can preoperatively plan to fix in the best bone to find the best site of purchase for that screw. I particularly like the coronal cuts, and you'll see those in just a moment, where we're going through, and you can actually see going right down the tunnel of the bone. So here's the coronal cuts, and you can see how we're coming from the vertebral body back towards the spinal canal. We know that we're safe. We're nowhere in the canal with these screws or implants, whatever we're putting in. And you'll see the pedicles coming into view. And then the canal. And here you can see we've got the best purchase, and I can put the biggest size screw to fill that pedicle as much as we need to gain purchase. Once we've got the plan done, we have the summary details. So I print this out and I hang it up in the operating room so the scrub technician knows exactly what implants I'm using through the whole case. Everything's laid out, everything's ready to go. We know the exact size of the rod. We've got everything set up so the surgery becomes that much more efficient as we're doing it. Once we've got the plan done, we set up in the operating room, we decide which mounting platform we're going to use, then we register. And this is the other benefit. Radiation exposure in the operating room has become a huge, huge issue. With this type of technology, we really only need an AP and an oblique X-ray. We get the X-rays, and then the software matches the intraoperative X-ray with our preoperative CT scan that has the plan on it. And it gives us a score, and it tells us that we're within 0.46 millimeters of accuracy. The difference between this type of technology and some of the other navigation technologies is this is segmental. So this software can recognize individual vertebral bodies, not a global section of the spine. So as opposed to being a global registration, this is segmental, one vertebral body at a time. And here you can see the trajectories that I planned to do a pedicle subtraction osteotomy on this patient. Once we've got that all planned out, we pick the screw we want to use, the clamp, and we've got the instructions of where we place it. And you can see here in this video how the robot is being set up. It's anchored onto the frame. The stations are adjusted up and down as needed. And then the robot is dispatched to the station where we want it to go. This is a percutaneous screw that we're putting in. And the first couple times you do this, this is pretty intimidating. You've got to rely on your proprioception. You really have to learn to trust your planning and your navigation to get there. You drill down, and then you essentially place your screw. And you can repeat this for multiple levels. Place your guide tube, put it down. Once the guide tube's in place, you can put your cement cannula down, you can put your balloon down into it, whatever it may be, and you drill and repeat for all the different trajectories. This is an example of a scoliosis case that I did. This was a 14-year young female with this double curve, progressive, listing off to the left, as you can see. And here's the preoperative planning. And for those of you who do deformity surgery, you can see how tiny it doesn't have a pedicle here, essentially. It's non-existent. Putting a screw in here would be a nightmare clinically. But with preoperative planning, we are able to plan exactly where we want that screw. We know where it's going to end up. We execute the procedure, and then we've got multiple screws in place where we can take her and realign the spine in the sagittal and coronal planes that we want to give her a balanced outcome with this. So this is one of the studies that we did looking at verification of the screws, comparing where the screws ended up pre and post-op. So we took the pre-op plan and a post-op CT scan and just measured the trajectory, the angulation of all the screws. And essentially the screws were pretty much right on. And we can go again side to side. This one you can see the starting point was 0.9 millimeters, just off a bit. Here in the sagittal plane, it's essentially sitting coaxial, exactly where we had planned the screw. And we can again go back and forth, slice by slice on this. So a number of studies have now been published looking at it. This was one study that we did. This was a cadaveric study. And this again is just looking at radiation exposure was the prime thing. But we had 14 surgeons, all of varying degrees of expertise. So we had interns, first-year residents, second or third-year residents, fellows, accomplished spine surgeons that hadn't used this technology, and then surgeons that had. And what we saw that the pedicle screw placement accuracy was not dependent on surgeons' experience. So the first-year resident was using this technology as well as the fellow and the senior surgeon. But what was very interesting also was that there was 50 times more radiation when these screws were placed freehand as opposed to using some kind of guidance technology. Now that's kind of intuitive because we're not using all those films, but it is very important. This was a paper published by Candlehart looking at the perioperative course and accuracy of screw positioning in conventional and open robotic-guided, percutaneous robotic-guided pedicle screw placement. So you had 57 freehand cases, 55 robotic cases, and what he concluded was that in the robot-assisted procedures, the rate of misplaced screws and the duration of intraoperative X-ray exposure was significantly lower, while the procedure time really did not differ significantly. This was a paper published by Dennis DeVito out of Atlanta, where he looked at 840 cases, 14 different hospitals with 3,271 pedicle screws in 635 cases. Almost half of them were percutaneous cases. 98% of the screws were clinically acceptable, and he concluded that robotic assistance offered enhanced performance in surgery when compared to freehand by increasing the accuracy and reducing the neurologic risk. This is a paper that I published recently in the European Spine Journal looking at our first 102 cases specifically. And we really wanted to just see what I learned from all of these cases, what I was able to do with them. We classified each one of the screw placements as successful, malpositioned, aborted, or not placed. In the first 102 cases, 95 of those we were able to successfully use them. 90% of those were some kind of deformity or revision type surgery. So of that, 960 screws were placed, 949 were successfully placed, 11 screws, 1.1%, were malpositioned. And one of them we had to revise, we had to take back. And I'll show you what essentially happened. So again, here you can see malpositioned screws, 1% with that. And this was sort of the learning curve that we looked at. We divided the screws into the first 375, then the next 300, then the next 340 to figure out what was going on. So successfully placed with the robot, you can see improved. So this is telling me that my planning has gotten better with it. Converted to manual placement went way down. So my execution in the operating room has gotten much better with it. And again, this one here less than 1% malplacement rate, so we're doing well with that throughout the whole learning curve. Now, the 11 screws that were misplaced were presumed due to skiving. The drill bit just came off the side of the facet joint. That's something that we've now learned to take into account, and we've created other tools to try to avoid that. But one screw, as I said, we had to take back to the OR because it was irritating the nerve. Now, these were the 7 patients that we tried to use the robotic technology on, but couldn't because of other issues. One has a patient with a body mass index of 45. This was a 6'8" individual that weighed over 400 pounds, and I thought that I could get away with it, but it just wasn't going to work. Someone with osteoporosis with severely soft bone, you're not going to get good x-rays, and you need good x-rays. Severe deformities like this are really difficult still, because when you do your x-ray, the computer can't tell the T8 vertebral body versus the L4 vertebral body because of the overlap in the x-ray. So these are the technical issues that we've learned over time and we're still trying to overcome. But I also wanted to look at how good we were, what was our accuracy in the deformity and revision cases. And again here, you can see, looking specifically at deformity and revision, 1% malposition rate. So we've been very consistent with that. So the screw placement was successfully accomplished with less than 1%. If you look at the literature, the reported malposition rate is anywhere from 4 to 15% for the complex and deformity cases. So I know we are doing a lot better with it. There are many advantages: minimize the intraoperative radiation, improve screw placement precision, screw pull-out resistance, and the deformity correction. The preoperative plan aids in the recognition of subtle anatomic variant. This type of technology does facilitate less invasive exposures. We can do percutaneous things, we can do vertebral augmentations, we can do all sorts of stuff with this, and it does enhance operative efficiency. But one thing I like to always say is that robotic assistance is not going to make a bad surgeon good. You still have to understand the anatomy. You still have to know what the proper indications for surgery are. You still have to know how to get into trouble and get out of trouble. What robotic assistance does is it makes a good surgeon more precise and more efficient. So what have I learned? Preoperative planning is very important. Let's try to reduce the radiation exposure. The technology is there, and it really is magic what we can do now. And there is a ton of future potential. We've seen all sorts of different devices that we can use, and you can easily see how you integrate this type of technology with the other types of technology. So with that, thank you very much for your attention.